Hi, my name is Ranjit Sapkota. I am a second year internal medicine resident at Advent Health Orlando. Today I am presenting a very interesting case of a pulmonary histoplasmosis in a kidney transplant recipient. Histoplasmosis is a condition caused by a dimorphic fungus, that is Histoplasma capsulatum, which is endemic to a region like Ohio and Mississippi River Valley. Infection occurs through inhalation of fungal spores. Although histoplasmosis is typically self-limited and asymptomatic, immunocompromised patients such as those with organ transplants are at higher risk of dissemination and severe disease. In renal transplant recipients, this incidence is about 3.3%. With this note, I would like to share this case of a very pleasant 33 years old woman with type 1 diabetes who had undergone a kidney transplant around 2 years ago, presented with persistent fever, chills, headache, photophobia, a dry cough, fatigue, and night sweats for a couple of days. She had recently moved to Florida from Tennessee, and Tennessee, the endemic region for histoplasmosis, as we know. On admissions, her vitals and physical examinations were unremarkable, and there were no signs of meningitis. Initially, she was started on broad spectrum empiric therapy, including antibiotics and antivirals, to cover for meningitis. However, the neurological causes are ruled out with normal imaging and lumbar puncture results. Then she underwent a CT chest, which revealed diffuse miliary nodules and focal pneumonia. Further workup showed positive urine histoplasma antigen, and the next generation sequencing confirmed the diagnosis of histoplasmosis. The patient was then treated with liposomal amphotericin for 1 week, then followed by the itraconazole therapy. She showed significant improvement and was discharged to complete a 12 weeks of itraconazole therapy at home. So overall, histoplasma remains a challenging case to diagnose because of its non-specific symptoms. Although most patients are asymptomatic, fever, weight loss, and pancytopenia are most common findings. Pulmonary involvements can be presented as miliary reticulonodular infiltration imaging. In extrapulmonary cases, it can be liver, spleen, bone marrow, CNS, or GI tract. Talking about diagnosis, it is most commonly made by detecting histoplasma urine antigen, which is most sensitive test, but fungal culture remain the gold standard, though it takes longer to diagnose. Molecular techniques like PCR can also aid in the diagnosis. Talking about the treatment, liposomal amphotericin B is the first line therapy for treatment, and that is followed by the itraconazole. This is important to prevent complications like chronic pulmonary histoplasmosis, mediastinal fibrosis, and disseminated infection. Finally, it's worth noting that despite treatment advancement, mortality from histoplasmosis in solid organ transplant recipient remains as high as 10%. This case highlights the importance of early recognition and prompt treatment of histoplasmosis, especially in high-risk population. So, lastly, I would like to conclude this presentation with 3 take-home points. First, we need to consider histoplasmosis in immunocompromised patients with non-specific symptoms, especially those coming from the endemic areas. Second, the urine antigen testing is a sensitive tool supported by advanced techniques such as next generation sequencing. Diffuse miliary nodules highly correlate with the pulmonary involvement. And lastly, liposomal amphotericin B followed by the itraconazole therapy is an effective treatment for acute or chronic cases of histoplasmosis. This is all about my presentation. Thank you very much. Have a good time. Thank you.